So I think it's time to start. Good morning, good afternoon, good evening to everyone participating in our webinar on Vulvodynia Clinical Answers. My name is Annamaria Giraldi, and it's a pleasure to welcome all of you and our outstanding faculty that will participate today. So thank you for joining us on this Sunday. Before I hand it over to our faculty, I just would like to introduce the International Society for Sexual Medicine for those of you who might not know us. We have a vision in ISSM that every human being has a right to a healthy and satisfying sexual life. To reach that mission or vision, we also have a mission, which will be on the next slide. And the mission is that we want to be the most respected and trusted source of information, education, and professional development on human sexual health through the delivery of world-class publication, research findings, online and in-person opportunities for knowledge exchange worldwide. And our series of webinars is a very good example of how we try to fulfill our vision and mission. And our society was established in 1982. And we have moved from only focusing on impotence in men to working with sexual medicine and sexual health in the whole field of human sexuality. Next slide. We are founded and based on regional affiliated societies. We have regional affiliated societies in North America, South America, Europe, the Middle East, the South Asian region, and the Asian Pacific region. And we also have the African Society for Sexual Medicine and are affiliated with ISSM, the International Society for the Study of Women's Sexual Health, being a very important group in the sexual field, the sexual medicine field. The next slide. If you are a member of ISSM, there are a lot of benefits. We have 4 journals: the Sexual Medicine Journal, the Sexual Medicine Open Access, and the Sexual Medicine Reviews. And we also have a video journal of prosthetic surgery. So if you would like to become a member and are not a member, this is one of the very, very big benefits of being a member, that you get access to all these 4 journals. The next slide. So it's a pleasure, having advertised a little bit about our society, to give the word to our moderator for the webinar, Marieke Dewitte. Marieke Dewitte is from the Netherlands. She's a psychologist and sexologist and an associate professor of the University of Maastricht. She's both doing clinical work and research, and her research involves psychophysiological studies in basic mechanisms of sexual functions and interactions between the partners and the patients, as well as on sexual pain. And she teaches on several courses, pre and postgraduate. She's the Secretary General of the European Society for Sexual Medicine, and she's also the Editor-in-Chief of the Dutch Journal of Sexology. So thank you so much, Marieke, for having time to be here and share your knowledge with us today. Thank you so much.
Thank you very much for the invitation. And first of all, welcome to all. I'm really happy with this webinar. Thank you for the introduction. I want to thank you for joining this, and I'm really excited about this topic because genital pain is a prevalent disabling condition. So I'm really curious to learn more about, and we have 2 experts today. Now, first, some practical issues. We will have 2 presentations of about 15 minutes each, and afterwards there's ample time for Q&A. Please send your questions via the Q&A button. So do not use the chat. If you have questions specifically addressed for the speakers, I will check only the Q&A for addressing the questions. And please also indicate to whom you are directing the question. So to which of the 2 speakers. So I will start with introducing the first speaker, which is Dr. Andrew Goldstein, graduated from the University of Virginia and University of Virginia School of Medicine. He did his internship and residency in obstetrics and gynecology at the Beth Israel Medical Center. Then he moved to Annapolis, Maryland, and he joined the faculty of the Johns Hopkins School of Medicine. And for more than 20 years, he's a director of the Centers for Vulvovaginal Disorders in Washington and New York City. He's currently a clinical professor at the George Washington University School of Medicine. Now, he's a very great person. He's a past president of the International Society for the Study of Women's Sexual Health. He has been involved in so many other sexual medicine organizations, has received several prestigious grants to pursue his research on vulvodynia. So he's really an expert, and he's a founder, president of the Gynecological Cancers Research Foundation. He has co-authored, co-edited 8 books, has written many landmark papers on female sexual dysfunction, sexual pain, vulvodynia, cervical cancer, and he's a great lecturer, as you will notice today. And he's also a great person. He has a strong commitment to global medicine. He volunteers also in South America, Southeast Asia on cervical cancer, and he's a great husband and father to his 3 children. So Andrew, thank you for being here, and please go ahead with your presentation.
Thank you so much. Can you see me? I hope so.
We can see you.
Excellent. Next slide, please. Well, again, thank you very much for having me. I want to again wish everyone a good morning, good afternoon, and good evening. I have the pleasure to speak about vulvodynia today. And as a good starting ground for this, I always go back to the 2015 ISSVD ISSWISH-IPPS consensus terminology. Prior to this new terminology, really vulvodynia was a black box. It was something that we really had no idea what it was. We had no treatments. It was just really pain of an unknown cause and of unknown etiology, and we really had very little to offer our patients. However, really 20, 25 years of very good research really pushed forward in the 90s, early 2000s, such that we were able to sort of open up this box and determine that vulvodynia is not one thing, but it's symptoms of several different disease states. And we really started to hone down on these different disease states. So this new terminology said that there are associated factors. And this is really a paradigm shift in the approach to vulvodynia. And these associated factors are incredibly important so that we can focus not only our research, but also our treatments on these different associated factors. Next slide, please. And this is the list of the associated factors that were outlined in this paper and the levels of evidence of these associated factors. So we found that there are other comorbid pain syndromes, very important in any vulvar or pelvic pain, both genetic, hormonal, musculoskeletal, neurologic mechanisms all contributed to different causes of vulvodynia. Very specifically a neuroproliferative type of vulvodynia. And of course, psychosocial factors play an incredibly important role. And Dr. Bergeron will be speaking about that in a few minutes. So what we can do now is we can use these associated factors and hone in on potential causes. And even though we know there's a lot of overlap in a lot of these, and specifically in certain women, we can start peeling away layers of the onion and therefore find specific treatments for women to help them. Next slide, please. Next slide, please. Great, thank you. And so today what we're going to focus in, actually go back, please, I apologize.
I think there's a little delay in the slides from you saying next slide.
Okay, thank you. I'll give it some more time. So what I'd like to do today is just focus on one of these associated factors, and that will be a hormonally associated or hormonally mediated vestibulodynia. So it's a subcategory of vulvodynia, just pain localized to the vestibule. And for the majority of women with vulvodynia, and that is the case, the majority of women had pain localized to the vestibule. And I use a diagnostic algorithm, which you can see just a part of it on the left-hand side here, and it's published in this textbook called Female Sexual Pain Disorders, which is a textbook of that all the proceeds go to ISSWISH. And this is just a small part of the diagnostic algorithm, which you can find at vulvodynia.com. But we're going to focus on the top left box, which is a hormonally associated vestibulodynia for the rest of this talk. Next slide. So the embryology of the vestibule is actually quite important. And we'll see why in a couple of seconds. But the vulvar vestibule is derived from the primitive urogenital sinus. It is the embryologic homologue to the male urethra. And you can see it on the bottom right hand side. And it's just between the Hart's line, which is a line on the inner aspect of the labia minora, which is the embryologic boundary between tissue that is lateral, which is derived from ectoderm, and tissue medially, which is derived from mesoderm. And the Bartholin glands, the Skene's glands, and the minor vestibular glands are the homologues to the Cowper's glands, the prostate, and the glands of Latreille. And so what are the implications of this embryology? Next slide, please. Well, the implications of this embryology is that the endothelium, it's not really a true mucosa, which would be a mesothelium. I apologize for that. I'm going to turn that off. I apologize. Shut off all your phones, but then another one will ring. The implications of this embryology is that the tissue is highly androgen dependent tissue. So it's not really estrogen dependent as much as you would think. It's actually much more androgen dependent. And so the Bartholin glands, the Skene's glands, and the minor vestibular glands are androgen-dependent mucin secreting glands. And so if you don't have adequate levels of androgens, these glands do not work and the tissue becomes thin, friable, and any contact can be quite painful. Next, and I want to point out that there was a really great review of this Sexual Medicine Reviews by Mazzaroli and Vignosi just last year, and it was really excellent. So I would encourage anyone to actually read this review to get a very in-depth understanding of the importance of the androgens in the vulvar vestibule. Next slide, please. So there are both natural causes and iatrogenic causes of androgen deficiency. The most common cause of an iatrogenic cause of androgen deficiency would be combined hormonal contraceptives, which lower free testosterone by suppressing ovarian production of testosterone as well as increasing SHBG. Another slightly less common, but we're seeing it a lot because dermatologists often use spironolactone for acne or androgenic hair loss. And spironolactone is an androgen receptor antagonist and lowers total testosterone production. Tamoxifen used for breast cancer lowers free testosterone by lowering total testosterone and also increasing SHBG. And of course, oophorectomy with or without hysterectomy, as well as just hysterectomy, even without oophorectomy, can lower androgens. Next slide, please. So the anti-androgen effects of the combined hormonal contraceptive pills, the pills, what they do is they decrease the pulse frequency of the GnRH from the hypothalamus, which causes, of course, decreased LH and FSH production from the pituitary, which causes ovarian suppression, leading to a decrease in ovarian production of total testosterone. The second way that oral contraceptive pills, as well as the patch and the ring, lower androgens is they increase hepatic production of SHBG, or sex hormone binding globulin, which binds to the already diminished levels of total testosterone, causing an overall reduction of unbound testosterone by at least 75%. Additionally, some CHEs contain progestins that act as antagonists at the androgen receptor, specifically drospirenone. And that was a common progestin in combined hormonal contraceptives really in the early 2000s. Next slide, please. So what are the consequences of these combined hormonal contraceptives causing decreased androgen production, and what happens to the tissue? Well, it will cause the glans clitoris to decrease in size. It will cause a decrease in size in the labia minora, a decrease in diameter of the introitus, as well as alter morphologic patterns of the mucosa. What you can actually see in the top slide is you have all of these nice reedy pegs, which act to prevent the top layer of the mucosa from separating from the bottom layer of the mucosa, interlocked sort of like this. But you can see on the bottom slide of the woman on combined hormonal contraceptives, she loses that. And so what happens is that makes the tissue more susceptible to mechanical strain and micro fissures, which can lead to infections and, of course, and to pain. There's also a decreased mechanical pain threshold when women are on combined hormonal contraceptives. Next slide, please. So there's a very significant literature that shows that CHEs can cause vestibulodynia, showing up to relative risk of 6.8, 9.3 of women if they start combined hormonal contraceptive pills early. So I don't have time to go through all of this literature, but the vast majority of literature has shown that combined hormonal contraceptive pills do certainly increase the risk of women developing vestibulodynia. Now, certainly not all women who take combined hormonal contraceptives develop vestibulodynia, but certainly in women who have vestibulodynia, you have to think of this as a potential cause. Next slide, please. So when a woman has a hormonally associated vestibulodynia, what they will have is they will have diffuse vestibular tenderness. So they have allodynia of the entire vestibule. You can see in this slide that the ostia of the glans are incredibly erythematous or red. The vestibule is also atrophic in appearance. It has sort of a diffuse pallor, so it's sort of white with red on top instead of a nice healthy pink color. Women will, of course, have an elevated SHBG and a low calculated free testosterone. Next slide, please. So this is a study that we did where we treated 50 consecutive women who developed vestibulodynia after they had started oral contraceptive pills. Again, the criteria was that they had pain throughout the entire vestibule. We thought that they did not have any overactive pelvic floor muscle dysfunction. And what we did is we just had them stop their hormonal contraceptive pills, and we treated them with a combination of both estradiol and testosterone at a 10-to-1 concentration of testosterone to estradiol. They had no additional treatments for their vestibulodynia, and you can see that their pain went from an average of 7.5 to approximately 2. So really, this was a very effective treatment for women who developed vestibulodynia after starting hormonal contraceptive pills. Next slide, please. So you can see in this before and after photo, you can see a classic hormonally associated vestibulodynia on the left, erythema, especially at the gland ostia. You can see the labia minora slightly diminished in size, the glans clitoris diminished in size, and just a very atrophic appearing vestibule. And this is after 4 months of treatment with an estradiol testosterone compound on the right. Next slide, please. The question is, however, what woman will develop a hormonally associated vestibulodynia? Certainly all women who take combined hormonal contraceptives don't develop pain, don't develop sexual dysfunction. So with the help of some very smart people like Mo Kohira and Erwin Goldstein and Noel Kim, they really pointed me in the direction of there must be some genetic cause to this. So we looked at polymorphisms of the androgen receptor gene, and we looked, and I'll just go over this very briefly. Next slide, please. And we looked at the number of CAG repeats in the exon 1 of the androgen receptor. So just very briefly, the more CAG repeats you have in this part of the gene, the less efficient the androgen receptor is. That means it needs more free testosterone to work. And you can see on the bottom right where the women who are the cases had significantly longer CAGs or more CAG repeats than the women in the controls who were taking the exact same combined hormonal contraceptive pill, but who did not develop pain. So this can explain why at least some women will develop hormonally associated vestibulodynia from combined hormonal contraceptive pills, whereas a lot of women do not. Next slide, please. We also very recently wrote a paper that showed that spironolactone will also do the same thing. So again, if a woman is develops vestibulodynia, sexual pain after taking spironolactone for maybe androgenic alopecia or androgenic acne, then you have to think about this as a potential cause of their vestibulodynia. Next slide, please. So in conclusion, we certainly recognize that all women who take combined hormonal contraceptive pills do not develop vestibulodynia. However, if you have a patient who develops vestibulodynia while she was taking combined hormonal contraceptives, even if her pain does not resolve after stopping them, and she has pain throughout the entire vestibule, please consider this as a potential cause, and as a potential treatment, have her stop the combined hormonal contraceptives and treat with a topical estradiol testosterone for at least 3 months. It takes quite a while for the treatment to work because you have to start ramping up the androgen receptors, which have been suppressed by the combined hormonal contraceptives. So again, this is just one small associated factor when it comes to vulvodynia. There are several others. Please take the time to read the Ishwar ISSVD IPPS classifications of vulvodynia, and this will really help you start trying to open up that black box of vulvodynia and pick specific treatments for women instead of just a one-size-fits-all treatment for vulvodynia. I thank you very much.
Thank you, Andrew. It was a great, insightful presentation. Now we will wait for questions until after Sophie has given her talk. So the next speaker is Sophie Bergeron. She's a full professor in the Department of Psychology at Université de Montréal, where she holds a research chair in intimate relationships and sexual well-being. And her research examines the psychosocial risks and protective factors underlying individuals' and couples' sexual well-being. Now, what is great is that she developed an empirically validated group and couple cognitive behavioral interventions for women with vulvodynia and their partners. Now, she's an associate editor for Archives of Sexual Behavior, member of the International Consultation of Female Genital Pelvic Pain Committee, and she's the current past president of the Society for Sex Therapy and Research. Now, Sophie has been my research idol for several years now. She's doing such great work, and I stayed in her lab for several weeks years ago. So I can tell you from experience that she's an intelligent, hardworking, and also a very caring person. So looking forward to your presentation, Sophie.
Oh, thank you, Marieke, for the kind introduction. It was so great. It's great to see you again, and it was so wonderful to have you in Montreal a few years ago. Thank you to the ISSM as well for the opportunity to share my work with you today. Next slide, please. I have no disclosures. Next slide. And here is an outline of my talk for today, which will mainly focus on our new cognitive behavioral couple therapy for vulvodynia. Next, please. Next. You can go when a slide, Lillian, has different sections to it. Yeah, thanks. So we know that 1 out of 5 women under the age of 30 complain of chronic pain during sexual intercourse. And this is also true of teenagers in a study we did with about 1,400 teenagers. And about 8 to 10% of women of all age complain of chronic pain during sexual intercourse. Unfortunately, only about 60% of those are going to seek treatment, and of those who seek treatment, only about half receive a formal diagnosis, suggesting that about 2/3 of women with chronic vulvar pain or vulvodynia do not receive adequate care. Next slide, please. Thanks. What we know as well is that women with vulvodynia present with some important distress. So in terms of anxiety and depression, which are both antecedents to the development of vulvodynia, so they are risk factors, but they're also consequences of living with a problem for which often you don't have a diagnosis, or it takes years before you receive a diagnosis. So that creates some distress as well. Beyond these broad categories of anxiety and depression, we also know that women live with a lot of guilt and shame and a sense of isolation because this is a more intimate pain condition. In terms of their relationships, some studies show that relationships are suffering, and others show that they're actually quite stable relationships for women with vulvodynia who do have a partner. However, what we know, and what we've known really from the work we've done and others in the last decade, is that there are specific relationship factors that are going to play a role in maintaining or exacerbating vulvodynia without them being a cause at all, but they're going to make the problem worse. And again, qualitative work has shown that women with vulvodynia do feel as though they're an inadequate sexual partner, and they're afraid of losing their partner, especially those younger women under 30. In terms of their sexuality, some of these women, unfortunately, suffer from most sexual dysfunction. So they have significantly lower desire, more difficulty with arousal and orgasm, lower sexual satisfaction, which is all understandable given that sex is painful. We used to think that the partners were doing just fine. However, 2 controlled studies in which our group and Caroline Pucal's group compared partners of women with vulvodynia to partners of women without pain showed that, in fact, about 75% of them were saying that it takes a toll on their relationship. Some presented with psychological distress. And in both studies, these men, they were male partners in the case of these studies, had more erectile difficulties. So they are really in need of attention as well. And this is part of the relevance of including them in a cognitive behavioral intervention. Next, please. The 4th International Consultation on Sexual Medicine that was led by Andrew actually made specific recommendations in 2016 in terms of where we're at with empirically supported evidence-based treatments. Next slide, please. And what was recommended as the 2 first-line treatments based on the evidence at the time was cognitive behavioral therapy and pelvic floor physical therapy. And vestibulectomy was also recommended, not as a first line, but after other treatments have been tried for certain types of provoked vestibulodynia, for which it works very well. And other treatments did not at the time have enough evidence to support their use as a first-line treatment, even though, of course, they may be helpful to some women. Next slide, please. Just a reminder that CBT is actually a family of treatments. So when you hear about mindfulness or behavior therapy, that's all under the umbrella of CBT, and there are different formats. Today, I'm going to talk more about the couple format, but it can be given in a group and in individual therapy as well. Next. So why is it relevant for vulvodynia? Well, it's the only treatment that targets those sexual difficulties and relationship factors directly. It's an important source of psychological support for that psychological distress that the women experience. And we know that CBT works for chronic pain, and I'll say a bit more about that on the next slide. And it's consistent with biopsychosocial formulations of pain, whereby both biomedical factors and psychosocial factors interact in the onset and the maintenance of the pain problem. Next, please. So there was a Cochrane review published in 2020 involving over 9,000 participants. And what they found is that CBT has small but robust beneficial effects for chronic pain conditions in terms of lowering pain intensity, disability, which in this case would be sexual difficulties, and distress of individuals. So that's quite strong evidence. Next, please. And CBT in particular aims to break this vicious cycle of pain, pain-related thoughts, emotions, behaviors that are, sort of a negative feedback loop of maintaining the chronic pain that many of our patients are kind of stuck in when they come to see us and their partners as well. Next slide, please. There's also specific evidence for the efficacy of CBT for vulvodynia, in this case, provoked vestibulodynia specifically. So in a study we conducted a while back, we randomized women to either vestibulectomy or group CBT or biofeedback, and we found that although vestibulectomy worked better in the short term, at a 2.5-year follow-up, CBT was equivalent to vestibulectomy in terms of pain reduction. Next, please. We also found in another randomized trial that group CBT was better than what at the time used to be prescribed. It's not really prescribed anymore, a topical steroid for provoked vestibulodynia, with group CBT being better on more dimensions of vestibulodynia, including pain and sexuality outcomes. Next, please. Here you can go through, yes, thank you, Lillian. So our intervention, our couple therapy intervention, is also based on a theoretical model whereby distal relationship factors, so relationship factors that people bring to their ongoing couple relationships, such as maltreatment or trauma in childhood, that are going to affect how they're interacting with their partner, and that these distal factors interact with more proximal factors. So what's going on between the partners right before sexual activity that may cause pain, during that pain experience, and right after. You can keep going, Lillian, thank you. And that this is going to affect how they regulate their emotions in the face of this threatening experience of pain, and depending on whether they use less adaptive strategies such as avoidance, which is a common understandable reaction but is not helpful in the long run, or more adaptive strategies such as acceptance of pain or disclosing how they're feeling in terms of this experience, that this in turn is going to impact, and you can go with the next one, their sexuality, pain, and relationship outcomes. Next slide, please. So I developed this intervention with Natalie Rosen and Serena Corsini-Munt, who are now each professors in different Canadian universities, and they did wonderful work in developing this manualized therapy with me. Next slide, please. And you can go one by one. Thank you. So here are the goals of the CBT treatment. So first we start with psychoeducation. So we see provoked vestibulodynia as a multidimensional pain condition. And so kind of the figure that I showed you earlier with thoughts and feelings, behaviors, and also we add to this couple interactions. And we give them information because they often lack information about what is vulvodynia. So we actually have them read some medical accessible papers. We really approach it from a couple's perspective rather than framing it as it's the woman's problem and she has to sort of bear the brunt of it alone. We really involve the partner and, you're going to find a solution to this problem together. We aim to improve emotion regulation, reduce distress, improve communication, increase pleasurable experiences rather than increase desire. We never frame a goal that way. We find it's counterproductive, but how can we help the couple facilitate experiences of pleasurable sexual activity? Reduce pain intensity and strengthen intimacy and maintain gains. They do a lot of at-home exercises to maintain the skills that they develop. Next slide, please. So this is the study that I'll focus on in the next few minutes, in which we randomize women and their partners either to CBCT or to overnight topical lidocaine. Next slide, please. You can go to the next one, thanks. So the CBT intervention, we piloted this intervention. We wrote a treatment manual, and the therapists were supervised every week. They really had to follow this manual. This is a 12-session intervention. Next, please. And we compared it to overnight topical lidocaine. For those of you who are familiar with this treatment, it's Denise Solnum's protocol, and it was prescribed and supervised by 2 gynecologists who were co-investigators. Women receive weekly phone calls to make sure that they apply the lidocaine every night and properly, and to answer questions. And we also gave them a bit of psychoeducation as well. Next slide, please. You can keep going. Thank you. This is the flow of participants in the study. You can press again. Thank you. And we had a 91% retention rate, which is excellent. Next slide, please. So here are the findings. In orange, you have the outcome measure, and I'm sorry I did not make these slides. I'll walk you through them. I realize they're a bit confusing or messy. So in the dark blue, you have the CBCT, and in the light blue, the lidocaine. So what we found for pain intensity is that both groups saw significant pain reduction with large effect size. Those are the Cohen's D's, but we didn't see group differences for pain intensity. Next, please. In terms of pain unpleasantness, which is the affective component of pain, we did see a difference whereby women in the CBT fared a bit better than women in the lidocaine group. Next, please. In terms of pain anxiety, so this includes fear of pain, avoidance as well. Again, and it makes sense that the psychological intervention yielded better results here relative to the lidocaine treatment. Next, please. We found a similar pattern of results for pain catastrophizing, which is really the tendency to ruminate and to feel helpless in the face of pain. It's the most robust predictor, psychological predictor of the pain experience across pain conditions. So here, CBT fared better. And we also asked the partners about their catastrophizing, and we found that both groups actually benefited just from being involved in treatment. Next, please. In terms of sexual function measured with the FSFI, both groups benefited. The partners, as measured by the IIEF, also benefited, but we didn't see group differences here on these standardized measures. Next, please. In terms of sexual distress, women randomized to CBCT fared better, and again, partners improved in both treatment conditions. Next, please. We wanted to have an idea of the clinical significance of the findings. So we first asked participants about their satisfaction vis-a-vis their treatment. And we found, again, the dark blue is the CBCT, that women and partners randomized to CBCT were more satisfied with their treatment. Next, please. And that, again, a standard question we ask in psychotherapy outcome research is what's their subjective impression of change in the broad dimensions of vulvodynia, so the pain and sexuality. And we found, again, that couples randomized to CBCT fared better in terms of changes in their sexuality, but we saw no group differences for changes in pain. Next, please. We also queried the couples in our pilot study to ask them we wanted to know about the acceptability of this intervention. And again, we had found in that pilot study that they were very satisfied with it, that they adhered to the homework and, as they would do in regular clinical practice, and that the interventions that they liked the most were actually those couple-focused interventions. So emotional disclosure, sexual communication, sensate focus, and some interventions that I've thought were particularly useful, like keeping a pain journal to track one's progress and psychoeducation. They felt they didn't appreciate these interventions as much. So it's always good to ask our patients what they find helpful and what we're offering. Next, please. Moderators of treatment outcome are important to investigate because they start to tell us who benefits most from which treatment. And I think we need to do a lot more of that research in vulvodynia. And what we found here is quite interesting, is that women, this was for the women only, who had high levels of childhood trauma, actually benefited less from the CBT and benefited more from the lidocaine. In terms of their sexual function, you can go to the next slide, please. This is about to come out in JSM. And in terms of their sexual satisfaction. So what might that mean? It could be that couple therapy with their partner and with a therapist talking about their sexuality is just too intrusive for women with really high levels of trauma. And also, this is a short-term therapy, so probably they would need a longer-term, slower-paced therapy and possibly without the partner. So this is something that we need to investigate more. And in the short term, they benefit more from a medical treatment that is less intrusive. So something to keep in mind when you make treatment recommendations. Next, please. You can keep going. Thank you. And then in a different set of analyses, we looked at, again, in terms of relationship factors, what were some of the predictors of treatment outcomes. So we found that independent of treatment, so whether it's CBCT or the lidocaine, those who were in a longer relationship benefited more from their treatments. Those who had less anxiety, and this is something we find just across studies, they fared better, whether in lidocaine or CBCT. And when partners had higher approach goals, so wanting to have sexual activity for a positive outcome rather than to avoid a negative outcome, and who were more supportive, those women also benefited more. So again, something to keep in mind when you make treatment recommendations. Next, please. And you can keep going here. So some of the take-home messages: CBCT works well. It can be recommended as a first-line medical treatment. This supports the ISSM 2016 recommendations. It benefits women in multiple outcomes. It benefits partners as well. And they also benefit from the lidocaine if they are engaged in the process. So I think independent of treatment, we really do need to engage partners a bit more. And CBT can be recommended as first-line intervention. Next, please. There's one more, I think, on this slide. Thank you. And women in a longer relationship with less anxiety and less trauma also benefit more from the CBCT. Next, please. So in terms of implications, you can keep going here. Findings also support our model, suggesting that it's worthwhile to target relationship factors. And we think in actual practice, when you can really tailor this couple therapy to the actual profile of the couple, it can be even more helpful. Next, please. I'll finish up with just acknowledging the Montreal team. It really takes a village to do this kind of work. Next, please. The Halifax team. Next. And our funding. Next. And I thank you for your attention.
Thank you, Sophie, for this great talk as always. So I think we're open for questions. There are already quite some questions in the Q&A. Please feel free to add your questions, and I also make sure that you indicate to which speaker you are addressing the question. Let's start with some questions for Andrew, for Dr. Goldstein. One of the questions, is the patch or ring less likely to cause vestibulodynia, or is it the same? Is it also worse with some brands or pills with lower estrogen doses, or doesn't it matter?
It certainly does matter, but everyone's biology is certainly idiosyncratic. So certainly even women on androgenic oral contraceptive pills can develop a hormonally associated vestibulodynia. In general, the combined hormonal contraceptives that have more androgenic progestins are less likely to cause this, you can't generalize to say, well, this woman is on an androgenic progestin, therefore this cannot be the cause of her pain. So again, if the pain did develop while after starting the combined hormonal contraceptives, whether that's any pill, patch or ring, and there's pain throughout the entire vestibule, just in my 20 plus years of experience, this is the most likely cause of the pain. But it is important to realize that all vestibulodynia, provoked vestibulodynia, is not equal. So for example, if there's pain only in the posterior vestibule, and this goes back to the diagnostic algorithm, which I showed earlier, then it's likely not to be caused by hormonal contraceptives. So you have to really hone in on the physical exam and the history to figure out what it potentially is, which associated factor is the cause of the vestibulodynia.
Okay. Also a related question, how often should patients apply the topical hormone combination? Another question in that regard is how long do patients need to use the topical hormones? You said it takes about 3 months to work. So once a tissue is healthy, can they then stop or will the pain come back? So it's a little bit how often and how long do they take the topical hormone combination?
It's typically, it depends on how sensitive they are to the medication. Sometimes they have to start every other day, working up to once and even twice a day. For the first 6 weeks, they typically find no improvement in symptoms. They are about 50 to 70% better at 3 months, and it typically will take 4 to 6 months to be 100% better on the regimen that I discussed. Once they're better, can they go back on combined hormonal contraceptives? Usually the pain will recur if they do, because again, most likely they're genetically predisposed. So in general, we don't have people go back on combined hormonal contraceptives. They can typically use progestin only hormonal contraceptives, whether that be the implant, an IUD, or just the pill. But the combined hormonal contraceptives, they typically do, it usually recurs.
Okay. Another question for you, Andrew. The vaginal microbiome is a dynamic state poorly understood and depends on hormones as well as other factors like seminal fluid or menstrual blood or personal lubricants, pelvic floor hypertones. So have you looked at the hormonal influence of the microbiome as it relates to vulvodynia? Because this person addresses, in my experience, hormone influences and androgens play a role, but the vaginal microbiome seems to play a bigger role in vestibular pain.
Well, certainly the microbiome is incredibly important. Again, as the questioner pointed out, hormones affect the biome incredibly, and so there's certainly an interplay. As the questioner also pointed out, pelvic floor hypertonus is incredibly important because not just tightens the muscles, but blood flow to the area, which can cause decreased blood flow, will cause not only hypoxia, but inflammation. So this is very complex. And again, this is just one of several associated causes of vestibulodynia. So certainly you have to pay attention. One of the things I'm sure the questioner is aware that, of course, changes in hormones affect risk factors for recurrent candidiasis, recurrent BV. And so again, they're all related. And again, I keep going back to the peeling away the layers of the onion concept, but you have to really start somewhere, and hormones are often a very easy, low-hanging fruit as to what is the cause of the vestibulodynia, along with pelvic floor muscle hypertonus.
Okay, another question here is, for some of my patients, I do not want to go off the contraceptive. So is there any study to show that the higher dose estrogen contraceptives may be beneficial in reducing some of the pain? Are there any options for these patients?
So there are no studies. In my personal experience, it does not work. Again, everyone's idiosyncratic, and maybe it would work on specific patients, but in my experience, it does not work. It's not typically the levels of the estrogen, but it's sort of the combination of the estrogen and the specific progestin. Maybe you would switch the not just go up in estrogen dosage, but change the progestin. Just in my experience, just switching between different types of combined hormonal contraceptives will not solve the problem, unfortunately.
Yeah. Maybe a final question before I move to Sophie. I'm a psychologist, somebody said, and she had a consultant for some years ago. She was in her 20s and she had pain during intercourse and she was in treatment with SSRI. So could this SSRI cause lower testosterone, and would she then have been a candidate to a topic treatment with testosterone?
The lower so SSRIs specifically don't lower androgens enough. Some small studies show they lowered them a little bit, but not enough probably to cause a hormonally associated vestibulodynia. Of course, SSRIs cause other types of sexual dysfunction, low desire, difficulty achieving orgasm, and possibly low arousal. So maybe those could have been the causes, because if you have low desire and you're not aroused, then you could develop sexual pain disorders, but probably not a hormonally associated vestibulodynia.
Okay. So maybe we'll come back to you, Andrew, but first maybe some questions for Sophie. One of the questions is like, what is the meaning of satisfaction for women with higher levels of trauma who use lidocaine to allow intercourse? Could this mean satisfaction that their partner could then enter with their penis? And how did you measure their presence versus dissociation in this cohort of women?
We didn't measure dissociation at all, and we measured sexual satisfaction. It's a broad measure of sort of the pluses and minuses, costs and benefits of their sex life. We didn't look at pain in this particular analysis. So your question is highly relevant, but it's a much more fine-grained sort of dive into this problem, which we've yet to do, but we certainly, these results really, we found them striking, and it piqued our interest to study more the relation between trauma and vulvodynia and how we can best address treatment for these women. Your question is very relevant, but we didn't dive that deep into it, unfortunately.
Okay. There's also one question to clarify what instructions are given for the application of the lidocaine. Do you know, by finger with a cotton ball?
It's with a cotton ball, and to use cotton underwear to keep it in place, and it's the size of a pea. So they actually had a figure that showed them how to do it, and then they had the gynecologist instructed them how to do it, and then they had those weekly phone calls with Lynn Ertz, who was a postdoc gynecologist. Yeah, we were lucky.
There's also a question because you propose a CBT protocol, and there are different types of psychotherapy, and one of the listeners is saying that sexuality is often linked to unconscious conflict, so maybe also psychodynamic psychotherapy must be interesting. She has 30 years of experience, and she found that these conflicts need to be treated as crucial factors, and maybe also because you mentioned that women with trauma benefited less from the CBT, would it be helpful for them to actually add other types of psychotherapy?
We don't know. I'm certainly in my, regular work quite eclectic in the approaches that I like to use with patients. I do like, though, to have a pragmatic approach. What I found is that if you don't address the pain from the get-go, and if you focus too much on sexuality, or you even hint that maybe there are psychological reasons to the pain, or maybe there are sexual reasons to the pain, first of all, there's little evidence that these are causes of the pain. The research doesn't support that. It only supports that they can exacerbate the pain. The same with trauma. It's not a cause. It's a risk factor. And that's, an important nuance. And a lot of women with trauma will never develop vulvodynia, right? So I think it's important to build the therapeutic alliance with these women, to really focus on the pain. That's been our approach, to focus on that psychoeducation about what pain is, how the pain is impacting their sex life, how the pain is real, do a lot of validation of that pain experience. And then depending on their needs and how they're progressing through the treatment, of course, I absolutely adapt all of our manualized approaches. We manualize it for research, but I would never suggest that in actual clinical practice, you can't diverge from that manual, right? You really have to adapt it to each woman that you're seeing, and depending if they're alone, it's a group with a partner. So there is room for psychodynamic approaches. I think you have to see whether the woman thinks that there's a link between the trauma and her pain. She might not see a link, or might not feel that it's relevant. But certainly, I think the key two keys. One is you have to ask about trauma experiences, even though they might not tell you from the get-go, but you still need to ask. And then one key factor in the therapy, any kind of therapy, is you really have to titrate sort of the arousal, the emotional arousal that is elicited in therapy, because if it becomes too high, that's when it's really challenging for people with trauma. Thank you.
There's also some sort of a critical question in the sense that you have great results with your sample, but one of the questions is, do you think that your experience with this relative small sample is sufficient to state that CBT could be considered as a first-line therapy for vestibulodynia?
Well, we don't use only this study, so absolutely the researcher in me says you need a lot of samples and you need a lot of studies. So it's just one with couple therapy. So of course we need more. However, in the case of CBT, at this point, there's accumulating evidence. So there's our studies with group CBT, there's our longer term follow-up, 2.5-year follow-up that shows that the gains are maintained. There's the work we did with Laurie Brotto about mindfulness CBT that works very well in addition. So and Robin Mashab looked at individual CBT, and all of these studies are showing that it works well. But again, like I think the point here and the point of what we're doing today is we need more of a multimodal approach, and not a single approach is going to help. You really they need a good physician. If you could have an Andrew everywhere, that's, you know, the best. And you just need that kind of quality care with the different health professionals all involved in the care and working collaboratively. That's the ideal. CBT is really by no means not the only approach that will be helpful. And it's also not accessible to everyone.
Now, you include a partner, and there's a big part reserved for kind of the couple approach, and also you see clearly that it has a lot of effects on the couple relationship. So it seems that vulvodynia is clearly a couple problem. But are there any pitfalls or challenges involved in couple therapy for vulvodynia? Are there any counterindications to recommend this couple therapy to women with vulvodynia?
Well, for sure. I think, you know, I mentioned one, which is high levels of trauma. I think you might not want to involve the partner from the get-go when that's the case, so you want to assess. Another finding that we discovered that I didn't talk about this morning is insecure attachment. For those of you who are, I know Marieke is knowledgeable about that. So women with high levels of fear of abandonment or high levels of fear of intimacy don't fare as well in the couple therapy. So that would be another counterindication where maybe you want to start either in a group therapy or with individual therapy or with something else altogether that's less intrusive than therapy, right? You can totally just start with a medical treatment or with pelvic floor physical therapy. So those would be some counterindications. And the other one, like the other pitfall, is resistance to a psychological approach. It's not for everyone. And depending as well how the referral is made, they might not quite understand sort of what they're doing in your office. And you have to work with that initial skepticism and see and involve the patient in their treatment decision making, and see, because now we have more treatments that are evidence-based, let them choose what they want to start with. Pelvic floor physical therapy has great evidence at this point, so maybe that's a better first line for them. They have to be involved.
Yeah, thank you. Maybe a few questions more for Andrew. One of the questions is also, did the biopsies reveal neuroproliferation in addition to the epidermal loss of reed ridges?
I mean, these patients, they did not. So we certainly know that a neuroproliferative cause of, again, another associated factor of vestibulodynia is neuroproliferation. That's typically related more to either a congenital abnormality or an inflammatory component to the vestibulodynia. So again, I know there's overlap in these conditions, but in this very specific group of patients, it was a very clear hormonally associated cause. You may have patients who, it may be much less clear. They may have taken combined hormonal contraceptives and developed pain, but they also may have had many infections. They may have had allergic reactions to possible treatments or other things that they've tried. So in these situations, there certainly could be an overlap between a hormonally associated vestibulodynia and a neuroproliferative associated vestibulodynia. For our study, we really picked pure stories in patients. So we did not see neuroproliferation in these patients, even though it was examined. But again, that is not to say that in some women there is not certainly a lot of overlap, and a lot of overlap with overactive pelvic floor muscle dysfunction. You know, it's funny. I showed you on the slide that it showed their pain levels went from a 7 to a 2. So the question is, if this was only the cause of their pain, why didn't they go to 0? Well, the reason they didn't go to 0 is, even though we said that they didn't have pelvic floor muscle dysfunction, as soon as we got rid of the main cause of their pain, we realized that many of these women still had overactive pelvic floor muscle dysfunction, even though we tried to exclude that. So that's sort of an underlying factor. Many causes of vestibulodynia are tight pelvic floor muscles. And so, to reiterate what Dr. Bergeron just said, it is incredibly essential to have a multidisciplinary approach that includes medicine, that includes psychotherapy, psychologists, but one of the real key components to this group are pelvic floor physiotherapists. I couldn't do my job if I didn't have a list of amazing pelvic floor physiotherapists, because a large percentage of women with vestibulodynia and any other type of pelvic pain have overactive pelvic floor muscles, and they really need to be addressed with physiotherapy.
Okay, maybe also a quick question. Have you looked into the relevance of interstitial cystitis as a cause of vulvodynia, and do you have any more information on mast cell stabilizers as a treatment option?
So certainly interstitial cystitis or painful bladder syndrome is an inflammatory condition of the bladder. There's a very huge overlap in women who have both IC and types of vulvodynia. That's for several reasons. There's crosstalk in the spine, so neurologic factors. There's both conditions will develop overactive pelvic floor muscle dysfunction. But I think what this questioner is getting to is the fact that mast cells are an incredibly important mediator for inflammation, both in the urogenital tract, so the bladder, the urethra, as well as the vestibule. So certainly, and mast cells cause inflammation. They also lead to neuroproliferation. So mast cell stabilizers, such as montelukast, such as cromolyn sodium, and as well as other antihistamines, certainly can be approached in specific women for vestibulodynia, and other conditions that lead to mast cell activation syndrome, such as Ehlers-Danlos syndrome. We really have to pay attention to the role of mast cells. They're incredibly important.
Okay, thank you. Well, we'll have to close soon because it's 4 o'clock. But maybe, if I may, can I ask one general question to close the webinar?
Marieke, we can continue if there are more questions. We have about, we can continue 10 minutes if the presenters have the time.
Okay. So then maybe I'll first ask a question that I was wondering, and then maybe I can go back to the Q&A, but it's actually a question for both Sophie and Andrew. More like, we know vulvodynia, it's not one thing, and genital pain is a very heterogeneous condition, and that has an impact on assessment. It causes a lot of diagnostic delay because we have so many different specific genital factors. So we're always focusing a lot on differences, the specifics of these different genital pain conditions. Is that helpful, or should we focus more on the overlap and develop kind of a uniform genital pain protocol, and that we then sort of pick out things depending on the specifiers, instead of developing these specific treatments for vulvodynia and then for endometriosis and then for these different types of genital pain? So I'm just wondering whether we, in terms of personalized sexual medicine, start from a general protocol and then try to sort of tailor it a little bit and take the ingredients that work for, instead of developing these very specific treatments for these very specific disorders. You know, maybe
you want to go, Andrew?
Well, I'll start. Well, I mean, I certainly agree that there is an incredible amount of overlap in almost all pelvic pain, both neurological, musculoskeletal, psychological, and we could develop a paradigm where we sort of focus on these, but I think that it's difficult to really cure people, really get them much better, as opposed to marginally better or moderately better, to really get people completely better unless you identify the specific etiologic factors in each individual woman's pain. So clearly there are generalities that we could use as a starting point, but I think it is important to really hone in on each individual woman's potential risk factors and really address each one of those sequentially and to get her completely out of pain.
Maybe Sophie, do you want to add something or?
Sure. I think, coming from a chronic pain perspective, I think there are more general approaches that can help. And going back to that pragmatism that I alluded to earlier, I do think that, and Andrew mentioned it earlier as well, that something like pelvic floor physical therapy is a good starting point just to calm everything down, and that it may facilitate receptivity or effectiveness of other treatments afterwards. So I think there are general things that are helpful. They're not all accessible to everyone, unfortunately, but in an ideal world, I think starting everyone with just a few sessions of pelvic floor physical therapy, a few sessions of CBT, psychoeducation, I think that would be really helpful if you could be in sort of a clinic where you have access, and you do assessments at least to identify what's going on. I think that can be very helpful, and with the goal to save time, because if we do just sequential one after the other, it takes a long time, and while time is passing, this cascade of psychosocial sexual negative consequences keeps going, right? So if you can address them earlier on in a multimodal way, I think that could be helpful for all types of pelvic pain, as you were saying, Marieke, and then hone in on the specifics, for sure.
I think it gets people, I think people, as soon as you do that, they start feeling cared for. And I think that that's really important. I think that I think much of many of healthcare providers really don't pay that much attention to these complaints, and so they don't feel heard, and they don't feel listened to, and they don't feel cared for. So I think that if anything we can do is to start them on the process of just feeling cared for, and it's really important.
I think that's crucial, and I had the opportunity to visit Andrew in New York and to see how he works, and I think that care factor is a huge part of the success that he has with his patients. Is he's so caring, and I think that's very important. The validation and the caring, very important.
Okay. Well, I think it might be good to close here, because we do have some smaller questions, some very specific questions, whether testosterone is available commercially and so on. But maybe I think that Andrew will be open to answer these questions. If people have questions, that you can email him, and that he can address these more specific questions that were posed here in the Q&A. But I think it's good to go back to Annamaria. I think it was a great webinar. I learned a lot. There were great questions. So thank you all for joining, and thank you for being also active and listening. And thank you for the presenters, because your talks were great. We learned a lot.
Thank you so much. Thank you so much for both Marieke for running this, and Andrew and Sophie for excellent talks. And usually the questions that we haven't responded to or haven't been response to, we will mail them to you, Sophie and Andrew, and if you have the time maybe to send a mail, that would be wonderful. So before closing the meeting, I just would like to thank all of you for being here. We have been more than 250 participants. This is really a lot of people, so thank you for being here. I think it also reflects that this is a clinical problem that is very, very difficult to treat and to get hold of. And this is something that many women suffers from. So I would like to advertise a little bit for the ISSWISH meeting. There will be the annual meeting in the International Society for the Study of Women's Sexual Health in Dallas, Texas, March 3rd to 6th this year. So if you would like to come to a conference where you deal only with women and hear a lot about how to treat female sexual dysfunction and a lot about how to treat pain, this is a very, very good place to go. Can I have the next slide? I also would like to advertise that the webinar will be made available on demand through the ISSM University. And also we have our next webinar on February the 28th, and that will be on a completely different topic, new therapies for erectile dysfunction. So I hereby close the meeting, and thank you, Marieke. Thank you, Sophie, and thank you, Andrew, for being here. And I hope to see you to our next webinar. Have a nice Sunday.